Well, welcome everybody. My name is Sheila Curran and I'm a family doctor, and I'm one of the doctors with the MaBAL program. And I just wanted to do a topic today that is, I think, one that gets a little bit less attention when we talk about hypertension in pregnancy. We always sort of think about acute presentations and people having seizures and strokes and things, but maybe miss opportunities in prenatal care or postpartum care to identify risks that we could maybe modify for women. So I wanted to share some information about that. So a little bit more about me. I live right now in Powell River, which is increasingly being called by its traditional name, Etiquette. It's on the traditional territories of the Slam and First Nation, who are actually a self-governing First Nation. So they do have settlement lands north of where I am, but I do live on their traditional territory. I have done most of my maternity and family practice career in the last decade in the Yukon. I'm a recent transplant here. So I have lots of experience being in really remote areas and dealing with complex transfers. And I think that will come up a little bit today. I also, whenever I sort of am doing a presentation or in a meeting or something and we do land acknowledgements, sometimes have some mixed feelings about it because it can feel maybe a bit pat or superficial to acknowledge the land and not also make efforts at reconciliation or improving things. But I think that by being part of our TVS and being part of services that are really geared at helping people in rural parts of the province, we have an opportunity to help improve the lives of rural people, many of whom are Indigenous people. So hopefully today we can keep in mind that some of the recommendations I make may be hard to apply in rural settings, and I'm happy for there to be discussion about that. So I don't have any disclosures. Nobody's ever given me any money to promote their products or services. As far as Zoom etiquette, there's none. Please feel free to interrupt at any time. I'm happy to take questions. I know it can sort of be awkward when we can't see each other, so feel free to just yell or pipe up, and I don't mind at all being interrupted. As far as gender and language goes, in maternity care, historically, we've always talked about women, and I'm personally making a concerted effort to change my language to talk about pregnant persons, because there are trans men who sometimes have pregnancies. It's a work in progress. Many of the resources that I use do not do that, and I've got some screen grabs and things that haven't done that. I am not very good at it yet, so you may find that my language is a little bit scattered with gender, and that's why. But I'm hoping to be more inclusive. So the goals for today is just to review what the hypertensive disorders are. It kind of changes all the time what the terminology is. You don't have to memorize everything. I really just want people to have some awareness of strategies. It's complicated and it's changing a lot. And if you're not doing maternity care all the time, this is really, I think it's easy to feel overwhelming, which is fine. We work in rural settings, which means we have niche areas of skill, and we need to be a network of providers working together. So we'll talk about, hopefully by the end of this, that you can identify risks for hypertensive disorders in pregnancy, identify when maybe you need to get some help for somebody, and go beyond just the routine, but you don't need to know what to do about it. You just need to know that there's some things out there to think about. So that's my goals. So definitions, this is going to be the sort of boring, dry part. You, again, don't have to memorize anything, but it is helpful to kind of know what we're talking about. I'll get into more detail, but this is probably the most important slide for definitions. So if a pregnant person's blood pressure is higher than 140 systolic or higher than 90 diastolic, it's too high. That's all you need to know. If it's higher than 160 over 110, it's way too high, okay? Of course, we need to confirm that by using our proper technique that I'm sure we all learned in nursing and med school or whatever else your training was. They need to be seated. You need to be in a calm, quiet area. You need to make sure the cuff fits right. And if you've done all those things and you do at least 2 readings, at least 15 minutes apart, and it's still too high, it's too high, okay? A few things to note is that it's really helpful if you get a baseline blood pressure early on in prenatal care. Sometimes for whatever reasons, maybe they've had some virtual visits, maybe they've had barriers to accessing care. You're in the middle of their pregnancy before you know what their blood pressure is. And as we'll see, that can make it a little bit difficult to figure out where you are later on. The other thing is sometimes it's really hard to know where somebody's blood pressure is. It seems so simple. It seems so concrete. It's numbers, but sometimes it's up and down and it's all over the place. And it's okay to just follow somebody closely, get them to come back in a couple of days if you're not sure. The other thing that you are probably aware of is that the norms for blood pressure do kind of dip a bit in the second trimester, and then in the last couple of months of pregnancy start to creep up again. That doesn't mean it's normal to be at these levels like 140/90, but sometimes we see blood pressure start to go up a little bit, and that's not always an alarming trend if it's still within the normal range. Just a slide to remind us that terminologies like fashions change for the better or for worse. I'll leave it to you to decide if it's too bad that we don't all dress like this anymore. So these days, the preferred terminology is hypertensive disorders of pregnancy. So pregnancy-induced hypertension is not used anymore. It's considered a vague term, and hypertensive disorders, as we'll see, encompasses more specific subcategories. HELP syndrome is still used, although, as we'll see, the Canadian classification doesn't specifically reference it, but it is still sort of like a subflavor of a hypertensive disorder that you may see. And that's about all you need to know about that. We don't need to get into details. So the hypertensive disorders, there are 4 main categories. Okay, these are them. We'll go through each one by one. So pre-existing hypertension means really that it's not there because of the pregnancy. It may be unmasked by the pregnancy, but they already had that predisposition. They were already hypertensive or usually on the verge of it. And we'll see them reaching those numbers of over 140/90 before 20 weeks gestation. Okay. We then further sort of subclassify that based on whether or not they have other comorbidities, other comorbid conditions is the terminology. So these are things that even in a non-pregnant person influence their risks from hypertension and their target blood pressures. So things like having kidney disease, diabetes, this is less common in the childbearing years, but cardiovascular diseases, if somebody's had strokes or heart attacks, for example, they already need tighter blood pressure control and have more cardiovascular disease risks. You can also get preeclampsia, and we're going to, down on number 3, get into detail about what preeclampsia is. And that would be defined as having blood pressure that's now resistant, developing protein in the urine, or adverse or severe complications. And we'll talk about those when we get to preeclampsia. Gestational hypertension is a disorder of the pregnancy. Okay, so we see that starting after 20 weeks, usually in the 3rd trimester, though when it's severe, it may start earlier. Same thing. If they already have kidney disease, diabetes, cardiovascular disease, they have a comorbid condition which complicates things and increases their risk. And again, they may or may not have preeclampsia. So same categories of having protein or adverse conditions or severe complications. So what are those? Okay, now we're on preeclampsia, so I will tell you. So for preeclampsia, you need 2 things. They need to be hypertensive, whether or not it was pre-existing or gestational, and they have developed protein in the urine. That's a sign of damage to the kidneys from the underlying condition. Okay. If you do a dipstick test and you see more than +1 urine, it's suspicious but not diagnostic. Okay. And so then where it's available to you, we would confirm that with a protein creatinine ratio, which even that I know is not always available to people. So then sometimes it's a matter of getting some help and trying to work through the diagnosis when you don't work somewhere where there's a hospital lab available to do a spot protein to creatinine ratio. Once that's confirmed, you don't need to keep repeating the urine all the time. And once the condition's there, it's there. Again, now they can have adverse conditions, and this is where we start to see damage to other organ systems in the body. Okay, so, and it's extensive. So you may have central nervous system effects. And I made this little girl on the side here because I think we're all going to have a headache after going through all of these definitions. And again, you don't have to memorize all of these, but I think it's important to understand how many organ systems this condition can affect. It's important. So they might get headaches or visual changes. Their cardiovascular system, if they have pulmonary edema, they may develop low oxygen saturation. So that's a very concerning finding. They might have chest pain. Their blood can be affected. They might start to hemolyze their blood, have anemia. They might have low platelets. They might have an elevated white cell count. You may see changes to their liver's ability to synthesize clotting factors and changes in their INR-PTT. As we know, it can affect the kidneys, and we see that with changes in their creatinine or uric acid levels. It can affect the liver, so that may present with nausea, vomiting, pain in the upper abdomen, liver enzyme abnormalities. Whoops, too far. And of course, it can affect the placenta and the baby, which are the other important consideration in any pregnancy, of course. So that may, it's really disorders of the placenta. So that may mean that the baby's not growing well, that the heart rate is showing signs of distress, that there's not adequate fluid being produced. You may see, if the placenta is really working poorly, that in between the baby's heartbeats, the flow in the arteries of the umbilical cord is actually slowed down or reversed. So the circulation is impaired. Okay. And then, so that's our adverse conditions. And then the severe complications are really worse versions of the adverse conditions, okay? And they're divided that way because that will help the people who are responsible for delivering these pregnancies make decisions about when the pregnancy needs to be delivered, when we're trying to balance keeping the baby in as long as possible, but avoiding harms to the mom or infant by allowing the pregnancy to continue. So this is when things can go really badly for the mom or the baby in preeclampsia, okay? So nasty things like eclampsia, which is seizures, okay? Swelling of the brain, strokes, okay? Hypertension that can't be controlled, pulmonary edema. That's actually one of the leading ways that preeclampsia can cause maternal deaths, heart attacks, really severe changes to the blood system. Come on. Some more severe changes to the liver, more severe changes to the kidney, and then more severe changes to the placenta. So it is a risk factor for abruption of the placenta, where it prematurely separates from the uterus and can cause bleeding to the mother or the baby, which is obviously bad, and worst case scenario for the baby stillbirth. So that's all the worst things. Now there's one last category that's our sort of sleeper one. It's not as exciting, but it's just something to park in the back of your mind. Okay, so you can have these other things like transiently elevated blood pressure that doesn't stay up, white coat hypertension where they're good in the office, but always have a high blood pressure when they're at home. Those things aren't as important to keep in mind. They're things you can work through if you come up against them. Any questions about that so far? These will be the sort of summary slides on it. Okay, so this is really everything I just said about the classification of them. It's available through the SOGC guideline. I see there's a chat there. I'll just have a look. Okay, thanks, Rebecca. That's good that I can see the chat. So if anybody wants to put a question there too, you can. I didn't know if I could see it or not. So this table is all available online through the SOGC's guideline on hypertensive disorders in pregnancy. And then this second table gets into the adverse conditions in the first column, and then the more severe versions of those in the second column. So again, you don't have to remember all of that, but just knowing that it's out there and sort of having your mind sensitized to it, I think is important. I have one of those brains that is not good with these details, but I'll know like, oh, there's a thing about if she's really nauseated and her belly hurts, like maybe it's not just gastritis, maybe I got to look up to see if it's something else. And then as long as you have your resources, you can go do that, or you can call MaBAL. So if I haven't convinced you enough by all the scary things that this matters, here's some statistics for you. So it's not that rare, okay? So it affects about 7% of Canadian pregnancies, and that's fairly steady when I looked up the stats. It really does represent damage to those organs. So when we see all those adverse conditions, it's because those organs have been damaged, okay? It does have a mortality rate. Our maternal mortality rates in Canada aren't super high, but there are a few stubborn conditions that are hard to improve on, and this is one of them, okay? And the mortality from this is equivalent to postpartum hemorrhage, and I think we pay a lot of attention to postpartum hemorrhage and preparing for that and doing emergency drills and being ready for it because it's scary and it happens fast, but this condition has an equivalent mortality rate. As far as the infant, there are lots of morbidities that can occur, and you know, we have healthcare that we can use to deliver these babies early, but to help them get over these things may require prolonged NICU stays. That of course has an influence on families, so it's not nothing. Oh, perfect. I'm just seeing Michelle's comment about downloading the SOGC. That's great.
I don't know if that's true, but it used to be true. I'm now a member, but I remember trying to get guidelines before. And if you're not a member, I think you don't have access.
Yeah, I think you're right. I'm a member now too, so I always just access it through that. And I'm happy to share it with anybody who wants to. This is kind of a side tangent, but I'll bring it up now anyway. I think this is kind of a complicated topic, and as we'll go on, we'll see there's not necessarily great consensus about what you should do for prevention of this condition. So one consideration is I think it's always really important that we practice in networks of providers and care locally. So whether it's, you know, the primary care provider, the nurse or the family doctor that your patients get most of their prenatal care from, whether it's a group of obstetricians, whether it's the referral center that you're connected to, and ultimately Perinatal Services BC. Hopefully within those networks, you have access to those resources. And through MaBAL, I think we try to be a bit of a provincial network as well. So sometimes I find that you can if you just Google them, they're out there, even if you're not through the SOGC site, but I'm not actually sure how available they are right now because I'm a member too. I will put my email as well, and I'm also happy to do that right now in the chat. Okay. And now I'm going to back up because every time I move through the chat, it somehow advances my slides. Okay, and then there are some so back to why it matters, why do we care? There are some long-term risks for the mother. So you've probably heard the expression that pregnancy is a bit of a stress test on the body, and it may unmask things like a predisposition to gestational diabetes or a predisposition to cardiovascular disease. So women who have had hypertensive disorders of pregnancy are at higher risks of developing essential hypertension as they age, getting coronary artery disease, having strokes, heart failure, kidney disease, and they have higher all-cause mortality rates than women who don't. So this is sort of an opportunity to have a little window maybe into their future health and hopefully help support them for improvements. My understanding is it's a bit less certain, but there have been some concerns about possible associations with developmental or behavioral disorders in the child. There's active inquiry into autism and ADHD correlations, and to whether or not the infant themselves has a higher lifetime risk of high blood pressure, which is a bit hard to tease out whether that's just because they got their mom's genetics or not. So stay tuned. It'll be interesting to see if those pan out into true correlations or not. Okay, next slide. I don't intend to dwell for a long time on the pathophysiology, so just bear with me, don't shoot. But I find it helpful just to kind of remember how complex this is. And it makes me grateful that my job is not being a physiologist or a subspecialist who actually has to know these things. So this is the kind of slide that would literally make me go to the bathroom and cry in med school, because I thought that I had to know these things to do my job. I don't, you don't. It's just helpful to have a little background knowledge about how it works, okay? So it's super complicated, as you can see from the slide, but a couple of things I would draw attention to. So this is really a disorder of the placenta. The placenta in these cases does not develop to be a healthy functioning organ. And that is ultimately at the root of the problems, okay? There's lots of causes to that. Many of them are not really things we can modify or do anything about. You'll see on the upper left, there's a huge immune system interaction, which is, interesting to note, hard to do anything about. But there are a few things like having macrosomic large infants, which we know is also associated with things like having gestational diabetes and with diet and exercise factors for the mother. We know that women who have metabolic syndrome have a little bit lower threshold to it. So if we can help address as much as possible their metabolic well-being, hopefully we can help help people have healthier pregnancies. And that is the end of that slide. So there's several risk factors, and as we go through, you'll see that some are modifiable and some aren't. Okay, so age is, you can't really do anything about that, but it is a consideration for maybe helping people choose to time their pregnancies for their early 30s rather than later. If a first degree relative had preeclampsia, if there's a family history of younger people with cardiovascular disease, those are all risks. Past medical history. So I've put underline the things that are sort of the major risk factors, and in red, the things that are modifiable risk factors. So it kind of mostly falls into things that already increase the risk of cardiovascular disease, and also things that increase the risk of blood that tends to clot. And then if, of course, like anything in healthcare, if they've had it before, they have a higher chance of having it again. And recurrent miscarriages, particularly with the same partner, can imply that there's a immune system factor with the two partners together. Okay. Also, if they've previously had a low birth weight, which is an absolute cutoff of less than 2,500 grams, regardless of gestational age, or a small for gestational age infant. So those are some things that you can kind of keep in the back of your mind as you're going through an obstetrical history at an early prenatal care. This is one of the 2 or 3 things where not smoking cigarettes puts you at higher risk. I don't recommend that people start smoking to modify their risk, but it probably is because smokers have a slightly more suppressed immune system. Okay. But then the rest of the things really get at nutrition and socioeconomic status. So just having lower socioeconomic status is itself a risk factor independent of other risk factors. Okay. But as we know that sometimes access to adequate nutrition overlaps with that. Obesity, access to healthcare to help with metabolic disease often overlaps with income levels. So unfortunately, this is a condition where I think there are where socioeconomic status overlaps and engenders further risks for the condition. And then particularly stimulant use can have an impact on the risk of preeclampsia as well. The conception factors, not a lot you can do, but worth being aware that particularly with things like IVF, there's a little bit higher risk, okay? And we tend to think of it of a little bit higher risk in first babies. So they maybe have been pregnant before, but not delivered a baby. But if their body's gone a decade since their last baby, it's a little bit of a reset, and they're back to a risk somewhere around that a woman would have a person would have in their first pregnancy. And then, whoops, conditions in the current pregnancy. So if early on their blood pressure is kind of borderline, you're going to want to watch them more closely. If they gain more than the recommended amount of weight, if they've had bleeding in early pregnancy, that can imply that the placenta is not forming in a healthy way. If they have infections, if there's problems with the fetus's growth, that means that we may have an unhealthy placenta. And then if they choose to do prenatal genetic screening, sometimes we'll see that those markers have patterns that might predict they're at higher risk as well. Okay, so now we know the risks, what can we actually do about it? For this part, I'm kind of going to go through and give some background information, but at the very end, I'm going to bring it all back together and just describe what my approach is to prenatal care. So there is a medical prevention, and that's using aspirin in the second and third trimester. It's given at bedtime in low doses, and that can help. Okay, so the evidence is, I would say, of moderate effect when we look at using drugs or other interventions for prevention. The numbers needed to treat are always pretty high. It's not sort of like using aspirin or Tylenol for a headache where most people will get better, or penicillin for strep throat. You have to treat a lot of people to prevent a few problems, okay? So these numbers would reflect sort of a moderate effect for a preventative treatment, which is, not bad. And sorry, I was just checking the chat. And it's pretty safe. Okay, so naturally, people who are pregnant are concerned about their babies. There's not any known increased risk to the infant, so that's good. Of course, we know that aspirin reduces clotting and can increase bleeding, so there's some concern about increasing in postpartum hemorrhage and abruption. I'm no expert in the literature, but my understanding is that that hasn't totally reached statistical significance yet, but it's there as a maybe, okay? And of course, then there's less severe but nuisance bleeding, like nosebleeds and, bleeding a bit more if you get cut and things. So, and that seems to follow higher doses. And there's not a lot of studies that have continued on following the infants after they were born, but a few that have as long as 18 months haven't noticed any issues around their development or childhood health. We don't have a lot of long-term though. There are some limitations, like there always are. For whatever reason, most of the participants in these studies are white North American or European women. Which doesn't reflect everybody, and particularly in the US, where in fact Black women have higher rates, probably associated with their barriers to care and socioeconomic status. It's a really unfortunate thing that the studies don't reflect that population. And there's a lot of variation in what the best dose is, what time it should be started, when it makes a big difference, when we should stop it. So there's not a really good consensus there. Another thing that can help, although it's maybe not as strong of a benefit, is calcium supplementation. So we know that a diet lower in calcium is associated with this condition. It's less clear that supplementing helps, but there's certainly no harm in supplementing up to a adequate level of intake, which should be 1 gram a day. And then there's a few other things that would be nice if they help. There's not actually evidence that they do help, but they're still worth recommending for pregnancy. So folic acid has no real bearing on this condition, but it's important for preventing neural tube defects. Exercise in pregnancy, probably because the die is cast early on when the placenta forms. Exercise doesn't, unfortunately, have any evidence that it helps with this condition. Presumably, it helps their cardiovascular system in general, but it doesn't have evidence. So you do it for the other reasons you recommend exercise in pregnancy. Likewise, smoking cessation, it has other benefits. This isn't one of them. And then there's other things that have been postulated that might help that don't. So again, they may or may not have reasons they want to do these things, but they're not worth doing for the sake of their risk of hypertension. So it's somewhat unclear and difficult to choose who gets aspirin. And again, you don't need to memorize this, but if you have some sense of it, then if it comes up for somebody you're seeing, you can think to ask. So I think one of the obstetricians I worked with said a few years ago, the question should be who shouldn't get aspirin in pregnancy rather than who should get aspirin in pregnancy. I don't know if I agree with that, but there are lots of growing indication, it seems. So we actually don't have a Canadian recommendation on this, and that's a bit tricky because we usually like to use our homegrown guidelines for things. The SOGC guideline that I've based a lot of this talk on endorses the use of it, but does not give any specific recommendations. So it's the choosing who where it becomes difficult. Okay. Some of you may be familiar with the Emma Clinic, which is a maternal fetal medicine subspecialty clinic at BC Women's Hospital. And they have a referral form that's a bit outdated now. And I say that because the MFMs who I've spoken to for phone consults have told me that it's a bit outdated now. And I think the pandemic has understandably disrupted their plans to update it. But we'll look at that. They have some criteria on there, but it's important to remember that they're really looking at referral criteria to their clinic to decide who might benefit from a more detailed assessment and specialized ultrasound. So it's not an exhaustive list of who might benefit from aspirin. Okay. There's a good American resource that is endorsed by both the American College of Obstetrics and Gynecology, or ACOG, and the US Preventative Services Task Force. So they have an updated guideline that's just a couple of years old now. And then in the UK, they also have a government agency called NICE that has its own guideline on it. And as we'll see, the ACOG one is probably most inclusive about who gets aspirin. So we'll have a look at those. So this is the referral criteria to the Emma Clinic at BC Women's Hospital. A couple of downsides to it. It's extremely complicated, but at least it's a checklist. Okay, it's available online. You can see that they break it into major risk factors and minor risk factors. This is the only resource that actually looks at those serum analytes that you may see come up on a prenatal genetic screen. Interestingly, this is sort of a side thing when it comes to prenatal genetic screening. They're very clear that the genetic testing is the statistics on it, the purpose of it is genetics testing. It's not really powered for doing screening for preeclampsia. However, if a person chooses to do genetic screening and then you have a report on these abnormal analytes, then you have the information and you can act on it. So it gives kind of cutoffs for that. So you may see that occasionally on a genetic screening result. And then they recommend, if they meet these criteria, that you start them on aspirin, get them on enough calcium, and get them referred to the Emma Clinic. Really, what they do at the Emma Clinic is assess for placentally mediated conditions. So hypertension is one of these, but so is abruption of the placenta, growth issues, and stillbirths. Okay, so there's some thought that a more prothrombotic state may be underlying this, and that's why they use aspirin for it. Just sort of a note on equity, going down to Vancouver, I know is not always easy for everybody. For lots of people, there's barriers to doing that, whether it's cost or distance or being uncomfortable being in an urban center, or supports for taking care of your other children. The main sort of special thing that they do there is a detailed ultrasound to look at the flow in the uterine arteries, so not the umbilical cord, but actually in the arteries going to the uterus, to try to predict a person's risk of more severe preeclampsia as the pregnancy unfolds. So, if you have somebody, you can always talk with your primary care obstetrical team about whether or not they might be suitable for Emma Clinic. And you can always call them. They're great. There's always somebody on call at BC Women's. You can ask them. I find, especially since the pandemic, they're really accommodating with virtual care, and sort of help maybe advocate for your patient and get an answer about whether there's a lot of benefit to them going down there or not. Because if they're just going to have an ultrasound and be told, we do some blood work and another ultrasound later in your pregnancy, maybe you could just do that rather than having them go down to Vancouver and be told that they'll get a little bit more monitoring in pregnancy. So I'd encourage you to sort of not just take these urban strategies for really detailed care as what we must do for our patients, but ask about what the real benefit is, and then have conversations with your patients and contextualize that. Talked about that. Okay, so here is sort of the breakdown of different risk factors for who should get aspirin. So as you can see, ACOG includes one more. Okay, so these are the major risk factors. If they have any one of these, it's recommended that they get aspirin. Okay. And I think these are mostly conditions that would get your attention at prenatal care, right? It's unusual to be taking care of somebody who's already got diabetes or hypertension or kidney disease. Those are high risk complicated pregnancies, and they should definitely be offered aspirin. If they've had a history of preeclampsia, that's important to know. Multifetal gestation, so twins, triplets, etc., is important. In the next slide, we'll see that the NICE guidelines include it as a moderate risk factor rather than a major risk factor. Presumably, all of us in primary care are going to be getting help with multifetal gestations anyway, so you can ask whoever you're going to refer them to what they think. So these are the moderate risk factors. Any two of these would be considered an indication for aspirin, depending on which guideline you and your local team choose to use. I know us in the Yukon, our obstetricians have recommended that we use the ACOG guidelines, so we've been pretty liberal with our use of aspirin or offering it to people. It's more to remember when you're using more specific indications, and it doesn't take much to add up, right? So if you've got somebody who's having a first baby and they are of lower income, that's aspirin. That's a lot of people right there. You can see that the ACOG guideline for obesity is also more inclusive. So they use a BMI cutoff of 30, whereas the UK uses a cutoff of 35, and likewise for age. So the American guideline uses a cutoff of 35, and the UK guideline a cutoff of 40. So it can be hard to decide whether or not to offer somebody aspirin. I think it's worth remembering that the preventative effects are moderate, and when there's not a clear best way forward, that's okay. You can talk to your patient. Are they somebody who likes doing everything they can to prevent something? Are they a kind of live and let live kind of person? And if that's the case, maybe this is something that you don't push on them, because there's a lot of heterogeneity in the advice still. So how do you use it? It should be started in the second trimester, so after 12 weeks, okay? There's some concern that it may increase risks of early pregnancy bleeding if it started earlier, and the benefit seems to be for after 12 weeks, but before 16, okay? And that just has to do with the arteries in the uterus transforming to supply the placenta, and the goal is to try to help those form well without clots forming in them, and develop as healthy a blood supply to the placenta as possible. The latest ACOG guideline actually suggests that you could go up to 28 weeks, which is the latest I've ever seen. Usually in the past, I've used 16 weeks as the cutoff, and if they haven't started before then, we've considered that we've missed the window, so that's interesting. I wonder how much benefit there is indeed if you start it that late, and if it's worth getting that fussed over, but that's something that we could always take case by case and get help from a consultant. There are different recommendations out there for when you should stop it. I know some experts who've recommended we'll stop around 36 weeks. It's unlikely to do much more, and then maybe we can mitigate the risk of them having postpartum bleeding, or bleeding if they go for C-section, or low, maybe iatrogenic low platelets from it. However, most of the guidelines actually recommend carrying on right up until delivery. So that's something that would be worth talking about with the team who's going to be delivering your patient if you're not involved in that side of care. I don't know why this is, but it's bedtime is the time that we recommend taking it. And the dose varies, but it seems that the evidence is pointing to a lower dose being just as effective with less bleeding risk. So right now, most everybody is recommending 81 milligrams. For calcium, as we mentioned, a gram of elemental calcium a day is what's recommended. So you have to look carefully at your formulation, because say 500 grams of calcium carbonate is only 200 grams of elemental calcium. So you need to make sure it's elemental calcium that you're getting. And there is an upper safe limit on that. And that's important for your women who are popping Tums for their heartburn. If you're taking supplemental calcium, they should divide it over the day, taking it all in one load. While practical, it doesn't absorb it as well. And taking it at the same time as your prenatal vitamin, or if they need extra iron, may get in the way of getting the iron. So it can be a little bit fussy in that way. Different recommendations vary. So it's like the Emma Clinic says, if they have lower calcium intake day to day, on average, just give them 1,000 milligrams. And the ACOG recommendation is just to try to bring them up to that 1,000 milligrams. With the upper limit being 2,500, you've got some room to play, and you can figure out what's practical. And then I wanted to talk a little bit about prevention in the postpartum period, because as we learned, there's some risk there as well. So usually ending having that placenta is the start of the cure for preeclampsia. But occasionally people do develop postpartum preeclampsia. It's usually going to be in the first couple of days, but it can be in the first 6 weeks postpartum. Okay. Otherwise, all the diagnostic criteria that we went through at the start are the same. Okay. So it's worth having that in the back of your mind if somebody is postpartum and they present with some of those symptoms like headache or shortness of breath or vision changes, where we're not sort of routinely doing blood pressure checks like we do in antenatal care. Long term, it is, like we talked about, an opportunity to modify their risks. Okay, so these are some statistics. This is from an article in Canadian Family Physician about future risks. Okay, so for, like we're talking about today, hypertensive disorders, lifetime, that person's risk of stroke in coronary artery disease are doubled. Their risk of having high blood pressure is increased by 4-fold. So they're not insignificant changes. Okay. And then other placentally mediated conditions like growth restriction, abruption, preterm delivery, or gestational diabetes in particular have really high rates for future health. So I've slammed you with information. You're probably wondering, what do you actually do with it? I will share with you my approach to care and would welcome comments on anybody else's or how you do it yourselves, or barriers that you see to doing it this way. Before I go on to that, any other questions?
Hey, this is Christina Thompson. Can you hear me?
Yeah.
Hey, so just for the aspirin indications, I can actually see gestational hypertension listed in either of the lists. So I'm not sure if that's being lumped with the chronic hypertension or pre-existing hypertension, because I would have thought gestational hypertension would be like an absolute indication for the aspirin.
Yeah. Do you mean in the current pregnancy?
Yes.
Yeah. Well, I think it's because up until now, most of the recommendations have been to start aspirin before 16 weeks. So by definition, gestational hypertension is starting later in the pregnancy. So I think the feeling is, because it's trying to prevent it in the first place, that it's too late to be beneficial by then. I suppose if somebody with the new American guidelines suggesting that you could start it as late as 28 weeks, if it would usually be a poor prognosis for severity if somebody developed preeclampsia before 28 weeks. In that case, they'd be having specialist care in any case, and I'd be interested to see if they'd recommend it in that case. But yeah,
okay, so right. So if we're seeing gestational I'm a GP, and so if I'm seeing gestational hypertension, I'm referring anyways. So then it would be kind of up to the specialist to decide if aspirin, but may be found not to be helpful then.
Yeah, that's right. And you might say, okay, I'm going to get you to a specialist, but I'm going to do, hey, I know that this is maybe a thing and you're having this high blood pressure start really early on in your pregnancy. I wonder if you should have aspirin, and knowing that they're going to get to the specialist in a week, but they're 27 weeks right now, maybe you phone them and ask, okay, I'm referring this patient to you. Do you think that they should start aspirin in the meantime? Is there a role for it or not? And get their expert opinion on that.
Thank you.
Yeah, which is why I think we all practice in different situations, but I'm always so grateful to have a really good network of OB colleagues who I can call or text or anytime with these questions, because there is so much of it that's really sort of provider and specialist discretion that is beyond our ken as primary care providers to kind of have an approach to.
I agree. Thank you.
Yeah. Okay, so what I try to do at my first prenatal visits is really see it as an opportunity to put together a sort of a risk profile for the pregnancy and all aspects of care. And I always joke with the women that I'm going to go first and I'm going to ask all my questions and then give them time later so that I can really understand and give them better answers and advice. And I try to do that. I really try to package it all up for them and say, okay, thank you for sharing the information. These are the things that I want to make sure we pay attention to in your pregnancy, and kind of lay it out for them. And that can take a few visits to get through. So the prenatal record does a pretty good job of helping us identify all these risks, but it's not perfect. Like, you kind of have to be thinking about their last pregnancy, not about their delivery, but were there complications within the pregnancy itself? And people don't always remember that. When you ask about their family history, it's not really geared to ask about their family's obstetrical history, so it's worth asking about that. Okay. It's harder now that we maybe do more of our first prenatals virtually to remember to make sure that they get baseline measurements early on, but that's helpful to have as a comparator as you go, and also assessing their calcium intake. I certainly am not capable of doing all of that and welcoming the patient to the practice and, asking the million questions that they have at their first prenatal in one visit. So I try to, connect with them more often in the first few months of pregnancy to kind of work through these things. Once you have their risks, I've just put it all in one table here for you, if that's helpful, just to kind of remember that these are potential indications for aspirin. And to help inform those conversations. So making sure that you really have thought about these things. And sometimes if you're not sure if they're kind of on the line, well, if they've got a lot of the moderate risk factors, that's maybe more persuasive regardless of what guideline you're using. This is a tool that I really like at all ages and stages. It's on osteoporosis.ca, but it's a little calcium calculator, and you can just go through and select your demographics, and then it will tell you how much calcium you're getting. You can just check off how much of different foods you're eating in a week on average. So I find that quite helpful, because I've gotten really no idea other than my lattes where I'm getting my calcium from. So it's a nice tool. And then once you've kind of gathered that information, you can plan care. And we know that starting aspirin is important, ideally before 16 weeks. So I try to have a bit of a plan of care before around 12 weeks if I can. Okay. It's a nice time to have these conversations about lifestyle and exercise. I think we live in a society where it's difficult to live in a different body, where people experience discrimination if they have obesity as a health issue, and it can be hard to talk to people about. And sometimes people have experienced eating disorders and things, and paying a little more attention to weight can be hurtful or triggering or difficult for them in various ways. So I really try to frame it as a discussion about health in pregnancy, and acknowledge that it can be difficult, and ask if it's okay for them if we talk about their weight in pregnancy. There are some, so there are some gestational weight gain charts through Perinatal Services, and Health Canada has their versions as well that you can use. And I like to do that on the day that we do their weigh or measure, and then they know why we're doing that, and we can look at it together and sort of help them see. It's also kind of helpful to know for people, what the target is, what they can expect to have as changes in their bodies. And it's often a surprise to people that over the trimesters, the rates of change in their bodies are going to vary. So I like to look at those together. If it's something you're interested in getting more training and support on, there is, through, again, Perinatal Services, and an online training that you can do called the 5 A's of Healthy Pregnancy Weight Gain, and it's got some toolkits and handouts and things you can order. If you don't do a lot of prenatal care, there are a couple of good resources, like a guide to sort of what you're supposed to put in, how you do the prenatal record. And it's a bit outdated now, and I hope that they will be updating it, but there is a sort of maternity care pathway that just goes into a little bit more detail. But the latest one that I could find on perinatal services is from 2010, so it actually doesn't even match the new prenatal records, but it's a helpful tool as well. If you have decided that you're either comfortable doing it yourself or sought some support and you want to start them on aspirin, you can prescribe it like this. So 81 milligrams to take at bedtime by mouth from starting sometime between 12 to 16 weeks. And then again, you'll have to decide, is it going to be 36 weeks or delivery that they stop it? When prescribing calcium, I find it easier just to do Tums because they're all going to get heartburn anyway. It's easily accessible. I know how much is in the dose, but you can do whatever you want. You can use pills that they swallow. There's other formulations of calcium. I find it most convenient to get the sort of extra strength Tums that have 750 milligrams. If they take that 3 times a day, there's their 1,000 milligrams of calcium. They can take it with meals, which is an easier way to remember it, and it still frees up bedtime to take their iron and aspirin together. That's just my approach. So then once we've sort of got everything teed up in the first trimester, I try to make sure people who are at risk are getting good monitoring of their weight and blood pressure. For a while in the pandemic, we were doing a lot of virtual care, and it's easy for this to slip through the cracks. But this is an easy thing for you to involve your patients in if you are doing virtual care. They can, if they have access to things like a blood pressure cuff, either because they can purchase it or you have loaners that you can provide to people and they have a way to weigh themselves. That's information that they can easily be taught to provide and can be involved in their care in that way. You'll want to make sure that they get their diabetes screen on time, and it may be some of these people also have risk factors that they should have it earlier. I sometimes forget to pay attention to the weight gain, but I try to do that and just inquire about their activity levels and their general wellness at their prenatal visits, and check in with them. You know, sometimes we recommend that they take the aspirin and calcium, and then we forget to ask, and we find out at like 34 weeks when they have preeclampsia that they were never taking it in the first place because they were experiencing some barrier or had questions that weren't answered or whatever. So check in. And then we talked about considering an Emma clinic referral, and they usually would see them sort of around 24 weeks. And then in the third trimester, the last few months of pregnancy, these are times when you really want to make sure you maintain the frequency of visits, and the visits become more frequent, usually every couple of weeks until the last month routinely, because we're more likely to see some of these changes happening, and we don't want a whole month to go by without an opportunity to identify them. If you're not sure and it seems like their blood pressure is creeping up, you can educate them about preeclampsia symptoms and see them a little bit more frequently just to monitor that blood pressure. And those don't have to be full prenatal visits. You know, it can just be a quick blood pressure check. And if it's fine, send them on their way. Or if there's somebody who can be taught to do home monitoring, they can do some home monitoring and follow up by phone. And then the same things, just checking in about their wellness. Are they using their aspirin and calcium? Are they having problems with that? The other thing that I'd encourage in this later part of pregnancy, when we're watching for any issues with how well the placenta is working, is that the symphysis fundus height is important too, right? So if it's not growing well, that may be an indicator even before high blood pressure that we've got a placenta problem. It's usually recommended now for women who have larger abdomens to consider doing an ultrasound for growth around 32 weeks. Okay. And you can use the nice little table on the prenatal record. Okay. Once they're postpartum, you can stop the aspirin. You'll want to keep following the blood pressure closely if they did have high blood pressure, and anticipate that with the ending of the pregnancy, it's probably going to go down. So make sure you're not over treating them with your blood pressure medications. And then I wanted to share this resource with you. I'm trying to do better with this and making sure that I actually see women at 6 months. So I'm like a recall task if I'm going to be their primary provider or encourage them to follow up. And this is something called the Mother's program. It's from Ontario, and they've published in the Canadian Family Physician Journal. And they have really great specific advice, like a recipe that you can follow for people who've had complicated pregnancies. So they would recommend close follow-up with the blood pressure, and then at the 6-week check, arranging some investigations to be done, and then continuing to monitor their blood pressure every 6 to 12 months lifelong. And they've got a nice handout that you can give to patients as well. And there's a reference for that. They've also got a cool app that kind of walks people through postpartum exercise and regaining fitness with the goal of helping modify these risk factors. And that brings us back to our objectives, which I hope I have achieved. Are there any questions? That sounds like a no.
That was great, Sheila. Thanks. Very comprehensive and really enjoyed it.
Great, thank you. Yeah, I'm happy to share the slides, Michelle. What would be the best way to do that, Rebecca? Like I'll condense them down a little bit, so it's just like the key slides, not like every single slide with words coming onto it. If I send them to Rebecca, do you have a way to distribute them?
Let me just see if I have Michelle's email. She did, I think, put it in. Can you put your email in the chat? I don't necessarily have everyone's email, depending on how they got this this ad. But Michelle, if you put your email in the chat, I can definitely send you the slides. I will put them on the site as well, on the MaBAL website. But that would need you checking that site a little bit later to access them. And maybe, Sheila, before everyone goes or before you go, you can just quickly talk a little bit about MaBAL and how people can connect if they don't already know about MaBAL.
Yes, totally. In fact, I've got it coming up. So yeah, so MaBAL is the Maternity and Babies Advice Line, and we are one of the real-time virtual support pathways. So the 24/7 ones where there's always a provider on the phone are MaBAL. Rosie, I think, is offline now, being reimagined, but we still have Rudy, which is the ER one, and Charlie, which is for pediatrics, and they're great. And sometimes we're not sure if it should be MaBAL or Charlie, but we can work together to work that out. And then there are these other ones that are really helpful for primary care as well, where you don't necessarily talk to somebody on the phone right away, but they're really helpful as well. If you go to the website down here at the bottom, you can get started. And if you're working in a health authority, you should have access to a Zoom account. But there's a phone number for each of the services as well, and it comes through to us on our Zoom accounts when we're on call. So you can call from any phone line. And yeah, so each of these can be added as a contact, except Rosie, which is not right now. And if you want to, you can just try calling us and ask what it's like and what you would do with it. And we're happy to talk. We're intentionally not on other services during our call days. And that is the end.
Thank you. That's so nice to hear this talk, and hopefully we can do another drop-in session, which will be advertised on our MaBAL page on the RCCBC website.
Yeah, great. Thanks for your tech support, Rebecca.
No problem.
Okay, take care. Bye, everyone. Have a good day.
Good afternoon.
Bye.